Good morning, everyone. We are in another session here in Neurosurgical.tv, your favorite neurosurgical education channel. I'm Uriel Taglevega from the Neurosurgical TV student team, and today we have a great session, JUHA'S Neurosurgery Grand Rounds. But let me introduce you to the great world-famous Dr. Juha Hernesniemi. Dear Dr. Juha Hernesniemi, good morning.
Good evening from here. So may I make my introduction to Professor Sbeih, and we go to our lecture. Is that okay?
Yes, please.
It's okay now?
Yes, it is perfect. Perfect.
Yes, doctor.
Welcome, Professor Ibrahim Sbeih. He will speak today on Farcotorial meningiomas. He's certainly one of the most important and well-known neurosurgeons of these times in the world. Of course, there are extremely many neurosurgeons, but he is very well known among all of us. So he made his medical training in Alexandria, Egypt, and after that had his neurosurgical training in Jordan, and after neurosurgical training in home country, made several fellowships in United Kingdom and has been more than 45 years in neurosurgery. This is the slide I always show, how to become a good neurosurgeon. I never saw a person wanted to specialize, who wanted to be a bad neurosurgeon. So train hard. So you should follow the way Professor Ibrahim Sbeih has done and is doing. Yes, extremely good training abroad and came back to his home country. There are different levels of manual skills. Number of repetitions and length of career are the main reasons for the level of manual skills. There is a common rule of 10,000 hours of training. You will go to the world top, and my own rule is that with 10,000 days in operation room, you are at the highest level of your career. Neurosurgery has three parts: operative skills, then research, both clinical and basic, mainly done clinical research by neurosurgeon. Teaching, Professor Sbeih has a high number of residents and fellows, has many publications, has been involved in extremely many congresses, live courses, and especially webinars. During the COVID time, he has given weekly his own personal webinar. He has been also very active in neurosurgical societies and social media. And as mentioned, he has been is very active in neurosurgical politics and teaching. He has been vice chairman of the World Federation of Neurological Surgeons, and then he's a member of the Cream of the Cream Academy, World Academy of Neurological Surgery, or invited neurosurgeons formed this very selected group. He's leader of many important societies in home country and abroad, and active editor in most international important neurosurgical journals, and active member of most important educational boards. He has been one of the pioneers in new treatments. He has done microsurgery of spine, long time, lumbar discectomy, 1985, in the first years when this method was introduced. Then has introduced also gamma knife surgery in his own country and Arabic area. Has been trained in skull-based surgery and has done transnasal approaches in infants. You should train your best young people. They should become better than you. We have seen here in our webinars talented residents and young neurosurgeons from Jordan, and I know also the daughter of Professor Sbeih is specializing in neurosurgery. So I welcome you, Professor Ibrahim Sbeih, and you will speak on Farcotorial meningiomas. We are waiting for this lecture. Please go ahead.
Thank you, sir. Cheers. Thank you, sir. I'm humbled by your generous remarks. To be here in your forum lecturing is the epic of my career. I'm so grateful for you for inviting me to lecture in your forum. It's a great honor and pleasure. Today I'm going to speak about Farcotorial meningiomas. This is the Farah Medical Campus where I work in Jordan. It's a new modern neurosurgical unit. And if you allow me, please, may I take a few minutes of your valuable time to introduce my country, Jordan, to you. Jordan is in the Mediterranean area, bordered by Israel, by Saudi Arabia, Syria, and Iraq. We have two seas, the Dead Sea and the Red Sea. This is the Dead Sea. Dead Sea, the lowest point on Earth. It says here 420 meters below sea level. Now it says 460 meters below sea level because of evaporation of the water by hot climate. Dead Sea is famous for having no marine life. It's high salt concentration. So if you just dip in the water will take you up and you can never get it down because it will just float up. Sceneries from the Dead Sea. Very touristic site for the Arab countries. Modern facilities. And a new conventional center which can take up to 5,000 seats. The famous mud bath in the Dead Sea. Leaving the Dead Sea, you can reach to the River Jordan, which is the recognized baptism site at the River Jordan. It's a touristic site, it is a holy site. It's been visited by the Pope. And in Jordan, we have about 18% of our population as Christians. Jordan is a very religion-tolerant country. We live peacefully together for many generations. Baptism site of Jordan. Pope visiting us many times there. And here the Pope himself overlooking Mount Nebo. And this is Madaba, the famous mosaic city with the very old mosaic map of the Holy Land. If you move back north, you will find the city of Jerash, which is the only preserved city outside Rome. This is the second city outside Rome with this Roman antiques and theaters. Jerash is famous for the yearly festival where everybody from all over the world comes and do concerts, singing and dancing. This is the city of Amman, the capital, and this is downtown Amman, where you found the very huge amphitheater, Roman amphitheater, which can take up to 15,000 people seated. And of course, this is Petra, the jewel of the crown of the tourism in Jordan. Very famous city, the seventh wonder of the world. And to go there, you have to pass through Wadi Rum, which is very majestic in its scenes. So many films of Hollywood have been filmed there. A very attractive touristic site. Wadi Rum itself and the old Hijazi Road, which is something like 120, 130 years old, connecting Turkey with the Arab countries. This is again Petra. And this is the other sea, which is Aqaba on the Red Sea, where you can do all sorts of sports, water sports. And this is my daughter doing some snorkeling there. And then the countryside, the eco-preservation in Jordan is very important for us. And this is where I live in Amman. People think of Jordan as a desert. It's not. Where I live is high. It's about 1,500 meters above the sea. So we have snow every year. And in 2016, I published this paper about history of neurosurgery in Jordan, if you allow me to take you through that. This is the first hospital in Jordan, built in 1927. It's called the Italian Hospital, still functioning. So many government hospitals in Jordan. And this is the famous cancer center in Jordan, world famous. Many government hospitals and universities. A lot of private hospitals. Jordan is a medical hub in the Middle East, and the revenues of medical tourism in Jordan is 1.5 billion every year. The first CT scan in Jordan was in 1978. Jordan was country number 8 in the world to acquire a CT scan. Of course, the MRI followed in 1987. And this is Queen Noor opening the first CT scan back in 1978. The first heart transplant in Jordan was 1985. And the first IVF baby was 1986. We have lots of modern technology. The PET scan and interventional radiology is practiced at the highest level. And the first neurosurgeon in Jordan was the late Anton Tarazi. He was the first Palestinian neurosurgeon and the first neurosurgeon in Jordan. He is a non-neurosurgeon of the two countries. Dr. Tarazi had his education in Jerusalem back in 1932. And here he is practicing some music with his Terasanta College for Boys in Jerusalem, 1938. He went to Montreal Neurosurgical Department, and he was trained under William Cohn, Arthur Elbridge, Theodore Rasmussen, Wilder Penfield. He got high degrees, and he was very much appreciated there. And this is one of his pupils, John Jane the Senior. He was trained under Professor Anton Tarazi, and he wrote, "I have remained grateful for Dr. Tarazi's dedication to teaching, and his influence has continued throughout my career." Dr. Tarazi came back to Jerusalem in 1961 and established the first neurosurgical unit in Augusta, Victoria in Jerusalem, which was then part of Jordan. And he actually in 1966 had the first Middle East Neurosurgical Congress. His pupil, Dr. Maraka here, back in 78, 79, performing craniotomy overhaul using Hudson brace. Many conferences were established in Jordan. This is 1979 first Arab-European meeting. I actually attended this conference as a resident. The first Jordanian Neurosciences Society was 1983. We actually applied for hosting the WFNS in Jordan, 2013. We could not make it. We came third to South Korea, Japan, before China, before Indonesia and Malaysia. And this is his Majesty King Abdullah receiving me and Professor Jack Brucci and the delegation that came to visit Jordan at that time, including many of our colleagues and neurosurgeons of the whole world. We actually established our first cadaveric microanatomy lab back in 2015, not 19, 2015. This is a very modern lab with 8 stations. And as Professor Yohannesimi told that my daughter is a neurosurgical resident, she's a final year. And this is the lab itself, where we trained so many neurosurgeons from around the world. We had so many courses. This is Professor Christ and Professor Vinko Dollins doing the courses in Jordan, and also people from the University of Vienna also doing microvascular anastomosis course. We were recognized as a skull-based training center back in 2008. This is the recognition of our center. And this is a certification from the World Federation that we are a recognized center for training. And also we're recognized as an international training center for residents. And this is the recognition from the World Federation. I really cherish this picture and I really looked hard to find it. This is Professor Charles Drake. And I believe Dr. Juha has trained under his command back there in Canada. He came and visited us in Jordan back in 1993. I really enjoyed his visit and I was taking him around, and these memories will remain with me till the day I die. Professor Yazarjil was in Jordan many times. I visited Japan back in 95 here in Tokyo Women Hospital. I was met by the emperor and of course part of the delegation of Jordanian government. Late Professor Kano, Professor Sano. I'm talking about people who actually visited Jordan. Yoko Kato, Professor Kawase, Professor Lindsay Simon, Albert Trotten, later Albert Trotten, Professor Spitzler, Roberto Heroes, late Evandro Oliveira, of course, Professor Nsemini visited Jordan, Majid Sami, Al-Mefti, Jack Marcos, Konovarov, Atos de Souza, Edward Lowe's, William Shaker, Nelson Oseko, with Professor Osama Al-Mefti, who visited Jordan many times, Evandro de Oliveira, Majid Sami, Professor Juha, Lindsay Simon, Atos de Souza again. Been part active part in the Asian CNS. This is us going around with the World Federation for many educational courses around the world. This was actually in Kazakhstan. ACNS Administrative Council. Here we met in China for the skull-based meeting. Myself and my son accompanied me there. The China visit. Here in Thailand, in Ukraine, in Japan, and in India. The many courses we did as education around the world. This is in Addis Ababa in Ethiopia. This is in Kiev. This is in Thailand. And in Jordan, we empower women. We are very much conscious about this. Jordan is a very open country, a very westernized country. And with the people like Garo So and my colleague from China, we are working hard on this issue. And last, this is the Black Irish symbol of Jordan. I hope I did not bother you by these pictures from Jordan. I will proceed with the lecture now. So my presentation is about Farcotorial meningiomas. I will give you an overview and I will talk to you about my personal series. So Farcotorial is a very specific type of meningiomas that arise here in the junction between the forks and the tent, Farcotorial junction. So it arises at any point along this junction, from the junction of gull and straight sinus here till the herpes, either above the tent or below the tent. So let's look at the Farcotorial junction. So this is the tent, this is the forks, this is the tent, this is the straight sinus, the forks, the tent, and the straight sinus. So you have to deal and know the anatomy of the Tintorial hiatus. So this is the Tintorial hiatus, and one has to know it by heart. if you want to operate on a Farcotorial meningioma. So this is the hiatus, anterior part, middle part, and posterior part. The crural cistern, the cistern ambiens, and the quadrigeminal cistern. So if you want to operate here, the anatomy here must be mastered. So hiatus is considered as anterior or middle or posterior against the crus cistern, against the cistern ambiens, or against the crural cistern. Again, this is from posterior. This is the straight sinus here. This is the edge of the tent. The structures involved, if you are coming to study the anatomy of the Farcotorial edge, are so many, and we have to know them by heart again. We have to know the arteries related there, the deep veins, the venous sinuses, the cranial nerves, the cerebellum, and the brainstem. Let's start with the arteries. What are the arteries that you can come across, you have to know about if you are dealing with the Farcotorial meningiomas? Posterior pericallosal artery, middle meningeal, accessory middle meningeal, meningioapophyseal, inferior lateral trunk, posterior cerebral artery, superior cerebellar artery, vertebral arteries. All these arteries supply the folks and the tent. And I urge the younger generation of residents and younger generation of neurosurgeons to read this beautiful paper that was written by late Albert Roten back in 2005 about the anatomy of the dural arteries. It is a must reading. So branches, as I said, come from the anterior cerebral artery, from the pericallosal or callosomarginal, where you have the posterior splenial artery, and then you have the middle meningeal. Or these branches, anterior branch, the betrothal branch, and the middle branch, posterior branch of the middle meningeal. So this is the distribution of the anterior branch, distribution of the posterior branch, and the distribution of the petrous branch of the middle meningeal. The other arteries, which is supplying the tent and the forks, is both the meningioapophyseal trunk here or the inferior lateral trunk here. So this is the inferior lateral trunk. This is meningioapophyseal trunk. The clival arteries, the medial and lateral tentorial arteries, the so-called Italian arteries. And from the inferior lateral trunk, the branches go to the superior orbital fissure, foramen rotundum and foramen ovale. This is an angiogram, lateral angiogram, showing you the meningioapophyseal trunk and the lateral trunk, inferior lateral trunk. Again, carotid inferior lateral trunk with its branches, superior orbital fissure, foramen rotundum, foramen ovale, and a branch to the tentorium, and of course the meningioapophyseal artery supplying the clivus, the medial and lateral tentorial arteries. So these are the Italian arteries, Bernasconi and Casinari arteries supplying the lateral and the medial tentorium. They are branches of the meningioapophyseal branch. Of course, here is the dorsal meningeal artery and the calvarial branches. There are branches to the tent from the posterior cerebral artery. And the famous artery is the artery of Davidoff and Schuster. It comes around the brainstem like this to go into the forks and the tent. So this is the branch of the posterior cerebral artery that supplies the tent, the PCA tentorial branch of Davidoff. Can you see that on normal angiogram? The answer is very difficult. Unless you have a meningioma there, you may not be able to see it. But if you have, you will see artery of Davidoff and Schuster as blood supply to these meningiomas. Blood supply from the superior cerebellar artery, meningeal branch. So this is how it shows on the angiogram. And also branches, meningeal branches coming from the vertebral artery, the so-called posterior meningeal branch, supplying this area, and beyond that into the tentorium. Another artery which we don't think of as supplying the tentorium is the ascending pharyngeal. Ascending pharyngeal does give a branch here to the clivus and to this part of the tent. These arteries are important because of the anastomosis. And if one thinks of embolization, one has to remember the anastomosis between the ascending pharyngeal, the middle meningeal, the accessory meningeal, and the branches that comes from the ophthalmic artery. So basically what I wanted to say is that this area, the Farcotorial junction, is very, very rich in blood supply and veins, very rich. Let's look at the venous system, which is involved, or one can come across dealing with the Farcotorial area. This is a very beautiful paper describing the venous anatomy using the 5 Tesla. Beautiful figures showing this complexity of the venous system by 7 Tesla. But my favorite diagram is this. In Professor Yazarji's book, which I had for so many dog's ears. It's fantastic picture. It's 3D. I don't know how Professor Yazarji and his man actually drew this. It's beautiful, showing the anterior septal, the thalamus striate, the internal cerebral veins, basal vein of Rosenthal, the vein of Galen, the straight sinus, and the Tintorial sinuses. Beautiful picture. And what I wanted to say, the message to take home for the younger generation is read from these books, read from Yazarji, from Roten. Please do not read from others. This junction between the veins is so variable. So you don't need only to know the normal anatomy, you also need to know the abnormal anatomy. So this junction where the basal vein of Rosenthal meet the others, so variable. Here it goes directly to the tip of vein of Galen, here beyond it, here into the straight sinus, here to the end of the straight sinus. So it is a must that one should know this. So please read from Roten, from Yazarji, from the scientific papers. Don't read from Mr. Greenberg. Greenberg is good for review before the exam. It's not a textbook. It says Handbook of Neurosurgery. So to make it as your prime reading as a youngster, as a resident, is to make a very grave mistake. Let's go to the quadrigeminal system. So this is just a pyramidal in shape. This is the floor, this is the roof, and this is the posterior part. The floor is made by the quadrigeminal superior and inferior colliculi, and we have the roof as vein of Galen together with the pineal gland, and here is the cerebellum as the lining this area. So this is the quadrigeminal system. Pineal gland, the pineal races, suprapineal races, the posterior commissure, the splenium, and the internal cerebral vein going into vein of Galen. So this area is not simple, it's so complex. If you look at the relationship of the Beyer matter, dura matter, arachnoid matter, you should know it also by heart. And the only way to know it is by going into cadaveric lab. You would know how complex that is. And when you know how complex that is, you would respect to deal and to operate on these Farcotorial meningiomas. Very beautiful paper about the arachnoid membranes around these structures. And here is the pineal gland sitting there above the superior colliculus with the 2 internal cerebral veins coming to join to form the vein of Galen. Another view of the quadrigeminal system from below, quadrigeminal system, quadrigeminal or superior colliculi, and then the quadrigeminal system. If you look from above, again, the complexity of the venous system is there for you to see. Internal cerebral vein, vein of Rosenthal, internal occipital vein, and vein of Rosenthal forming the vein of Galen. Again, the complexity of the venous system in that area, which will connect with the posterior fossa veins. So this is the view that you will face if you are dealing with a pineal lesion or with a meningioma or the Farcotorial junction. These are the internal cerebral veins joining to form vein of Galen. This is the precentral vein of the cerebellum. This is internal occipital vein draining the medial part of the occipital lobe, and this is basal vein of Rosenthal. If you open here the tent, like we do here, then you will see the internal occipital vein and the important vein, which is the anterior calcarine vein draining there. And this is important knowledge to know because you may cause blindness if you are not aware of this type of venous relationship. Remember that your veins at the quadrigeminal cistern, they will connect and they will drain the posterior fossa veins. So if this is basal vein of Rosenthal, you'll find this is the lateral mesencephalic vein, which is draining the superior petrosal vein. So damage here would cause also damage to the brainstem. This is the intricacy of dealing with these meningiomas. What about the thalamus? Certainly you have to know the anatomy there very well. Pineal gland, apennula, posterior commissure, superior colliculus, pelvinar of the thalamus, and the lateral geniculate. You will come across the medial surface of the hemisphere, i.e. medial surface of the temporal lobe and medial surface of the occipital lobe. So this is the calcarine sulcus, getting in continuation with the parieto-occipital sulcus, but here it will continue as calcarine sulcus. So you will have the cuneus here, the precuneus there, lingula of the occipital lobe there, and this is the parahippocampal gyrus. So you will come across these structures and you have to know them well. So this is the view to the quadrigeminal cistern. You are above the superior vermis and you will come across the gyri, which I mentioned, the parahippocampal gyrus and so on. If you go above the tent, folks, and tent, then this is the calcarine sulcus. You have the cuneus and the precuneus there. This is the parieto-occipital sulcus. What about the tentorial sinuses? Tent is full of tentorial sinuses, and damage to these can cause neurological deficits. Beautiful paper by Matsuoshima of the different types of the tentorial sinuses. Cerebellum. This is the tent. If you remove the tent, you'll come on the tentorial surface of the cerebellum. Here you can see vein of Labey, which can be damaged easily if you are not careful. This is the straight sinus, the tentorial surfaces of the cerebellum. And here is the, have removed the superior medullary vellum and the superior cerebellar peduncle, and you are looking into the fourth ventricle. So if you are operating here, you can cause damage to these structures. So you are so close to this connection of the cerebellum with the dentate nucleus. Brainstem is there, just millimeter away, superior colliculus, inferior colliculus, inferior colliculus, superior colliculus, and this is the trochlear nerve, and this is the midbrain and pons. So we have to draw the line between the difference between tentorial meningiomas and falcotentorial meningiomas. Tentorial meningiomas is the broader term. The subdivision is the falcotentorial meningiomas. Falcotentorial is a subtype of tentorial meningiomas. So let's start first to look at the tentorial meningiomas and then go to the falcotentorial meningiomas. Tentorial meningiomas, which is the broader terms, any meningioma in the tent, it's 3 to 5% of all meningiomas. So many classifications to that, but the best I could find, and most of the people would agree, that Yazarjil had the most accurate and the emphasis on the surgical anatomy is there. So what did Yazarjil say? He said there are median or medial, and then the paramedian, and then the lateral. Median, paramedian, and lateral. And in the midline, you have this as falcotentorial or this as torcular. It's very simple, straightforward classification. Medial, intermediate, and lateral, falcotentorial, torcular. Examples of the Yazarjil classification. These are the medial types. These are the intermediate types. And these are the ones which are occupying the falcotentorial junction or occupying the torcular itself as we go backwards. This is torcular meningiomas. Other classifications were done by Wilhelm Shaker from Seattle, United States, back in '84. But what he did is to modify the classification of Yazarjil. Professor Sami also tried to do the classification, again, classified them into two groups, lateral tentorial and the tentorial incisorial group. And then came Hisham Basuni from Eastern Germany. Again, he adopted a modification of JUHA'S classification into 6 groups instead of 5. Recent classification from China, Cheyenne Quinn, published 2021, classifying them into T1, T2, T3, T1 anterior, T2 is middle, T3 is posterior, and then subdividing T1 into A and B and C, whether it is central, whether it is posterior or medial. Again, the middle type infratentorial, supratentorial, or both. And T3 into A, B, C, D, superior, inferior, lateral, and straight sinus. It's a very good classification, but a little bit cumbersome. So now to Falcotorial meningiomas. They are just 0.3 to 1% of all intracranial meningiomas. Again, remember, this is a subdivision of the Tintorial meningiomas. And they can occur at any point across this line from the junction of the forks with the straight sinus or along the straight sinus. Are they common? No, they are very rare. Michael McDermott, a very famous meningioma man from San Francisco, in his paper, in his book, chapter 11, said that he could count 100 cases in literature. 100 cases of Falcotorial meningiomas have been reported. Very rare indeed. And he actually listed the authors and the year of publication. From Japan came Tomita back in '95, and he reported 7 cases. Again from Japan, Okami in 2001 reported 4 cases in a long period of time, 91 to 99. From USA, again, Michael McDermott, early paper, 2003, 6 patients within 3 years. And his center is a referral center in San Francisco, in the United States. From University of Rome, over 20 years, only 13 cases, published back in 2004. Again, from Argentina, from Benedicto Colli, my friend, he reported 7 cases of Tintorial meningiomas. From Brazil, I mean, sorry, Benedicto. From Germany, Hisham Basuni in 2008 reported 13 cases, and he made his classification for these meningiomas. From Barrow Neurosurgical Institute, again a referring center, a very big center in the United States, in the period of 10 years, they had only 14 cases. From Spain, 2019, 2 cases. So they are really rare type of tumors. The best classification, as we mentioned, the best classification of Tintorial meningiomas were the JUHA'S classification. Basuni made the best classification for these Falcotorial. I really love this. It is very practical. It's very much to the point, and it is really helping you in doing the surgery. He said we'll have 4 types. When he published this paper 2008, reporting 13 cases, he made them into 4 types. Type 1, it originates from here, from the forks, at its junction with the tent. The very junction of the forks and the tent is this meningioma, like in here. So he called it type 1. Type 2 is the same, but inferior. So the difference between this one, type 1, above, and this one is below the junction of the forks with the straight sinus. Type 3 is origin along the tent, and it could be paramedian or immediately on the tent and the straight sinus itself. This is type 3. So type 1 and 2 are here, one above, one below. Type 3 is along the straight sinus, and type 4 completely taking the whole of the straight sinus. This is the most difficult ones. How do these cases present? As you would expect, they would present with headache, with hydrocephalus, which is the main presentation. Pressing on the cerebellum will cause ataxic gait, and the other manifestations is usually visual. So 45% visual. The main presentation are headaches and ataxic gait. Others, of course, can be the presentation. Weakness, psychological, epilepsy, incontinence, etc. Let's concentrate on the visual. We have two types of presentation, either Perinaut syndrome or homonymous hemianopia. Henri Perinaut, a French physician, described this Perinaut syndrome. Basically, this is a midbrain compression at the level of the superior colliculus. So this is the cut, and this is the crus cerebri, this is substantia nigra, and this is the radionucleus, the third nerve, median fasciculus and superior colliculus. So pressure in here would cause this syndrome. And this is made of certain items. Conjugate abort parsi, people cannot look up, and we see this in hydrocephalus, we call it sunset appearance. They have convergence nystagmus. When they look laterally, they have nystagmus. They have poor light reflex. They have weak accommodation reflex because they are involving the third nerve. And as I said, this is the sunset appearance we see in hydrocephalus. And there is a little bit of lid retraction. Let me show you this video showing this. I'm just trying to fix that. There it is. As you can see, there's nystagmus on looking laterally. She cannot look up. There is loss of upward gaze, and the nystagmus and the lid lagging. So we're describing the visual manifestations, we describe the Perinaut syndrome, and now we look at the other visual manifestations, which is homonymous field defects. We have to remember the visual pathways, the optic nerve, the chiasm, the tract, and the loop into the temporal lobe, and the optic radiation into the visual cortex. You can see this in the DTI, you can see it in the tractographies. Nerve, chiasm, tract, lateral nucleate body, and Meye's lobe, and then the optic radiation into the visual cortex. Beautiful. All these anatomy pictures were taken from Yazerjil collection. Professor Yazerjil visited Jordan many times. He's like father to me, like father figure to me. And I really followed his steps. I visited him many times. I learned a lot from him. To me, he's a role model, and I will not forget him so long I live. So this is the optic tract, and this is the lateral geniculate body, and this is the Meye's lobe, and this is the optic radiation. This is lateral geniculate. This is the Meye's lobe and the optic radiation. Again, you can see this in the DTI and the tractography. And in the lateral dissection group, the fiber dissection group, you can see the lateral geniculate body with the optic radiation. Of course, optic radiation comes lateral to the tabitum of the corpus callosum in relation to the occipital horn of the lateral ventricle. So here is the calcarine sulcus. As I said, this is the parieto-occipital sulcus. This is continuation of calcarine sulcus. On the lips of the calcarine sulcus are areas 17 and 18, the primary visual cortex, and the areas around them are the visual associated cortices. So the primary visual cortex, area 18 and 19, is mainly concerned with the awareness of visual. You just know that you have a visual stimuli. You just are aware of this. But to process it, to understand it, to recognize it, and to memorize it, you have to have the help of the visual associated areas. And this beautiful paper from Japan depicting the optic apparatus on DTI. And the most importantly, they looked at what type of visual disturbance would you have according to where the lesion is in relation to the calcarine sulcus. In this case, the arrow here points to the calcarine sulcus, and they say, oh, this is anteromedial to the calcarine sulcus. While here, this is posterorostral to the calcarine sulcus. And in here, this is posterolateral to the calcarine sulcus. So where the lesion is in relation to the calcarine sulcus will give you a visual field defect. So this is congruent right inferior hemianopia, and this is macula sparing due to what? Left occipital lesion above the calcarine fissure. So the type of visual field defect that you will get depends on how many millimeters this lesion is in relation to the calcarine sulcus. This is incongruent visual field defect due to involvement of the inferior optic radiation. So the visual field defects, whether you are dealing with the optic radiation or the visual cortex, and where in the visual cortex, macula sparing or not macula sparing, depends on where is the lesion in relation to these structures. What about the images of these Farcotorial meningiomas? MAMRI is the best. Shows you the relationship. In this case, the tumor is above the junction of the internal cerebral vein of vinogram. Here it is in the middle. Here it's taking both different types of Farcotorial meningiomas that I could find in literature. Each and every one of these is a different story. It's a different line of management. It's different expertise. In this particular case, this is turcular type of meningioma. And this is one of my cases. 54-year-old female patient who came with multiple meningiomas, meningomatosis with these meningiomas, and a Farcotorial meningioma. So Farcotorial could be part of meningomatosis and could be part of other syndromes. Angiogram to me is a must. Be it MRA, conventional DSA, CTA, it is a must. MRA is the weakest one of them. It will show you general information, but nothing specific. I don't underline it. I do not count on it. You go for CTA. In this CTA, you can see the abnormal vein of Rosenthal, huge abnormal vein of Rosenthal draining into the straight sinus. You would actually, doing a conventional angiogram, you would see the actual blood supply of these meningiomas, the meningio-hypophyseal trunk. Here you can see the tumor blush coming from the meningio-hypophyseal trunk. Here you can see the blood supply coming from the posterior choroidal artery, a branch of the posterior cerebral artery. And here it's coming from the posterior meningeal branch. Vinogram is another must. I would not even think of operating without having a very illustrative vinogram and angiogram telling me the whole lot of arterial and venous relationship. And the most important for me is this, MRI, SWI, the susceptibility weighted image, which is important. So MRV, okay, it will give you general information. I don't count on it. I will go for SWI, and I can see the septal vein, the thalamus striate vein, the internal cerebral vein in details. And I think this is a must. Once you are dealing with these venous structures, whether you are dealing with intraventricular tumors or otherwise, you have to have this venous anatomy well illustrated. Septal vein, joining thalamus striate, internal cerebral vein, vein of Galen, etc. And this is one of my patients where we have done vinogram showing the drainage into the cavernous sinus, superior petrosal sinus, inferior petrosal sinus, the whole lot. The angiogram would show you these details, would show you here that the junction of the straight sinus and gallin is infiltrated by the tumor, but it's still patent. Here, the internal cerebral vein is pushed down. Here, gallin is occluded, and the straight sinus is partially occluded. CT venogram is a must, and it shows you the venous anatomy in that area beautifully. Again, here the tumor, and here you can see that by vein of gallin is closed, and the transverse sinus is faintly seen. Closure of vein of gallin, there is collateral drainage. And this collateral drainage is important. People forget about that we have something called falcine sinuses. We have fetal, embryonal fetal sinuses within the folks. And these can open when there is an obstruction. So this is one of them. I really don't know, I don't understand how people would operate without having full detailed study of arterial and venous anatomy, not only for the relationship, but for the abnormalities. Another venogram here showing this meningioma of the tent blocking the straight sinus, the transverse sinus. And again here, tumor also blocking it. This is very serious. A common intraoperative finding is a patent vein or a sinus which was not visualized preoperatively. So you do your studies and you think this sinus is closed, and then surgery showed that this is patent, and this is a dilemma. Venogram showing the relationship with these venous sinuses again and again. Also, the study, the venous anatomy study would show you the Tintorial sinuses, beautiful paper showing this. And this is important because you'll be dealing with the tumors in this area. And again, here, as I said, opening of these fetal falcine sinuses that were actually closed but open up when there was any obstruction. Not everything in the quadrigeminal system is a Farcotorial meningioma. There is a very important differential diagnosis. I'll just go through with you. A germinoma, a teratoma, embryonal carcinoma, a choriocarcinoma, pineoblastoma, yolk sac tumor, ependymoma. It looks very much like a meningioma here. Astrocytoma, one of my patients, I went there thinking that this is a meningioma. It was an astrocytoma. Oligoblastoma, oligodendroglioma, a parenchymal tumor intermediate type, one of my patients. And a very important issue is this. Sometimes we don't recognize the difference between a Farcotorial meningioma and a vellum interpositum meningioma. And this is important. Vellum interpositum meningioma is a meningioma arising from the vellum interpositum. It has no dural contact, and it is within the third ventricle, while the Farcotorial has a dural contact. They are two separate entities, and we should not mix them. Farcotorial has a dural attachment. Vellum interpositum, no dural attachment. Farcotorial supplied by posterior choroidal artery. The vellum interpositum supplied by Tintorial arteries. Farcotorial pushes vein of gallin anterior-inferiorly, while the vellum interpositum pushes them posterior-superiorly. So major difference, and one can tell, but most of the time you discover this at time of surgery. From Poland came this paper about this Farcotorial and vellum interpositum. It says there are two distinct entities of the pioneer region, and I cannot agree more. From USA 2003, meningiomas of vellum interpositum, surgical consideration for this, from Jeffrey Bruce. From India, very beautiful paper, 2014, giant meningioma of posterior third ventricle, Farcotorial or vellum interpositum. Again, the differentiation has to be made. Two cases of this vellum interpositum from Japan, 2015. What is the treatment of these Farcotorial meningiomas? Microscopic surgery, endoscopic surgery, radiosurgery, and radiotherapy. Let's go through them quickly. Just starting saying that these tumors are most complex of tumors. They are most challenging of tumors, and the learning curve is steep and long. Microsurgery aim is to gross totally resect the tumor. It's the surgical resection is the treatment of choice. And if you look into literature, gross total resection is done in 50 to 70% of cases. There was not a single paper showing a gross total resection in 100% of cases. You can't. The surgical approach must be tailored individually. It is time-consuming surgery, and people would talk about long surgeries taking about 12 to 23 hours. So some people would say, let's have 2 surgical teams so that you would not feel exhausted. Position, sitting position, semi-sitting position, prone position, concord position, 1/3, 3/4, whatever you call it, approaches. Basically, either you are going infratentorial or supratentorial. So you have supracerebellar infratentorial, you have occipital transtentorial, you have interhemispheric transsplenium, you have combined supra-infratentorial, and you have the newly described bioccipital supra and infratentorial. I'm talking about what is written in literature here. So let's see the supracerebellar infratentorial. This was described by Spitzler. You can go in the midline, paramidline, or far lateral. And again, a beautiful paper by late Albert Roten describing which area you would go to when you use the midline or the paramidline or lateral. Eventually, you will go here. You have to know the anatomy by heart. You have to know the venous anatomy beforehand. You have to study it carefully. You can cut the tent from below, and then you come to the medial surface of the occipital lobe and the temporal lobe, like in this here. The supratentorial, transtentorial, occipital transtentorial is easy to describe. Again, forks and tent, devoid of the bridging veins. This is a straight sinus here. You cut the tent parallel to the straight sinus. So here your tractor would come across or on the calcarine sulcus or on the cuneus and the visual cortex, and you can cause damage. Once you are there, you cut the tentorium parallel to the straight sinus, about 1 to 1.5 centimeters. You open the tent, you have the quadrigeminal cyst here in front of you. So, as in this here. And the newly described occipital transtentorial falcine. So, transtentorial and falcine. So, you do the same, you open the tent parallel to the sinus, and then you go into the force and open it. So, you are opened here, and you have opened here. And then you can go across to the other side, like this. So, you can take the tumor in this area. Again, a newly described approach is the bilateral occipital transtentorial transfalcine approach. Case from Brazil, 2005. From Japan, 2020, about bilateral bitentorial approach for these giant Farcotorial meningiomas. A beautiful paper from Watanabe. You have the combined approach. You go infratentorial, you go supratentorial. And early, I could find the literature, this paper by Dalham Shaker and Atul Goel back in, I think, 1993, describing this combined approach. Michael McDermott, again, the meningioma man from San Francisco, described this back in 2009. And in his book in 2020, the combined approach with beautiful illustrations. And he put the cases, and I really made this mark about this. In his cases, what was the examination post-operative? Cortical blindness, cortical blindness. All of them had major visual field defects. Luckily enough, all of them recovered. Now this is important. I remember Michael telling me personally, Ibrahim, you tell the patient once, twice, 8 times, 10 times. You consult with the patient, you consult with the family. There is a visual importance here. He may have a cortical blindness. And once it happens, they don't understand it, although you have explained everything to them. So you have to say it once, twice, thrice, 10 times until you make sure they understand the risk of this surgery. Microsurgery regarding sinus repair and grafting remains controversial. Some people do it, some people do not. And this is a paper about sinus repair by Ibrahim Sbeih. John, there is some noise disturbance.
Yes,
Hello?
I'll get it.
Thank you. So sinus repair, as I said, is controversial. This is the paper by Ibrahim Sbeih describing taking the tumor from inside the sinus and repair it. Of course, George Bernard is very famous for his techniques in sinus repair, especially in the superior sagittal sinus and parasagittal meningiomas. What about endoscopy? People are trying to do this, especially for pioneer tumors. A paper 2011, taking tumor from the pineal area. 2018, using pure endoscopic infratentorial supracerebellar approach. Endoscopy is advancing. Endoscopy, in the endoscopist hands lies the future of neurosurgery. I believe in this strongly. Endoscopy will take over in maybe 1 decade or 2 decades. What about the complications of this surgery? If you look generally in the literature, before 1980, mortality was very high, 16 to 44%. After 1980, it got less, 3 to 10%. What types of complications? Weakness, hydrocephalus, imbalance, memory disturbance, speech disturbance, new cranial nerve deficits, CSF leak, what have you. Some kind of complications of venous infarcts. The visual complications, which I described before, homonomyopia, scotoma deficits, visual hallucinations, cortical blindness, and you may cause by your surgery a Perinaut syndrome. Why is that? Why do you get visual defect? Because you have a cause damage to the upper lip of the calcarein fissure where the primary cortices are. Ischemic damage to the straight cortex. When you cut the tentorium, you have cut some collateral venous channels without knowing it. And most important and the most common cause is urotractor over the precuneus. Examples of these complications seen on DW1, the ischemia in the occipital lobes, bilaterally causing bilateral blindness, ischemic changes in the occipital lobe, and again, a beautiful paper, a very beautiful paper about the blood supply and the blood, the ischemia that's happening there due to these kind of surgeries. Clinical features and pathophysiological mechanism of the visual complications after occipital transtentorial approach. And you can see here. What about radiation? IMRT or radiosurgery is used when you get residual. Radiosurgery is used. This paper from Jason Sheehan from North Carolina, describing 35 patients with not Farcotorial meningiomas as such, but for a Tintorial meningiomas. 35 patients for the increase in volume did not respond. From Mecca of radiosurgery, from Dade Lansford and Konziolka, paper treating 41 patients, Tintorial, again, not Falcotintorial, but Tintorial, and they had 2 increased in size. Complications of radiosurgery must not be forgotten. There are 8%, 3% are transient, 5% are permanent. So radiosurgery does not come without a price. This is one paper describing the late development of trigeminal neuralgia after radiosurgical treatment of a tentorial meningioma. Now the final part of my presentation about my personal experience with these cases. Over a 30 years period, more than 30 years period, 8 cases, and I consider myself lucky because the whole literature only contains 100 cases. So to have 8 cases, I am lucky. I insist on having full neurological examination. I ask the consultation of my neurology colleagues, ophthalmology colleagues, and I ask the psychiatrist to perform Karnofsky performance scale for every patient before and after surgery. When I start surgery, and these are my principles, I put an external drain into occipital horn. I don't like shunts. I don't like to start treating the patient by doing shunts. I try to remove the tumor. If it goes well, that's it. If not, I will put a shunt. But I would not walk into putting a shunt. A good shunt is no shunt. So putting an external drain in the occipital horn will facilitate this for you. This is the full ophthalmological examination, visual acuity, visual fields, color vision, optic OCT, etc. And these are the principles I talked about, that family and patient must be counseled, that there are maybe few days to few weeks of cortical blindness, which may persist and may recover. Karnofsky performance scale, as I said, is done. Do I use embolization? Very, very rarely. Most of the authors would agree that this is not usually successful because of the fine vessels, because of the anastomosis there. But some cases you may need to. I use the neurophysiological monitoring for all patients, and I use the neuronavigation. And this is one of my patients using the special endotracheal tube to monitor all the cranial nerves in the posterior fossa. Sorry. I basically mainly use the semi-sitting position. My staff are very much used, and we did not lose any single patient for an air embolism. Intraoperative Doppler is used to identify transition between patent and occluded segment of venous sinuses. So you can divide the sinuses accordingly. If the venous sinus is infiltrated by patent, leave. If the sinus is occluded, you can ligate at the lateral margin using the Doppler. As I said, a good shunt is no shunt. So don't start by putting a shunt. Maybe you'll be able to relieve the shunt by just taking the tumor out. Remember a very important thing, which is the trigeminal cardiac reflex. You are working and then the anesthetist will tell you, stop, I have a cardiac arrest. That's simply because you are touching the Farcotorial area, which is rich with nerve supply. This is the nerve supply of the tent, very, very much rich with the supply. Just touching it will cause cardiac reflex, trigeminal cardiac reflex. This part of the Tintorial notch is less nerve supply than this, and usually are working in this area. My way of doing the supracerebellar infratentorial, and I will take you through it with still pictures. These are my cases. This is the opening. You are looking at the occipital surface of the cerebellum. You proceed supracerebellar infratentorial, and you come across the most severe thickening of the arachnoid in your body. This is the area where the arachnoid is very, very much thickened, and you cannot really see through, and you really don't know where the veins are. So you have to be patient and experienced to do it. So then you start to see the veins. You see the precentral vein, you see vein of Rosenthal. Precentral vein can be, most of the authors would agree, that can be sacrificed. So once you do that, you'll come across the tumor. You proceed. So this is vein of Galen, and this is vein of Rosenthal, and precentral vein. This is one of my cases. Here I'm exploring the fourth trochlear nerve by removing the tumor from here. And this is the bed of the tumor at the end. The colliculi being flattened by the tumor. And then you can look into the cavity of the third ventricle. This is vein of Galen. This is precentral vein, which we could preserve. So if you look, then you can see the roof of the third ventricle in the semi-sitting position. You can see the choroid plexus. You can see both foramina of Monroe. Again here, very beautiful view. I was lucky to get this picture from one of my cases. This is the choroid plexus and the roof of the third ventricle. And this is the massa intermedia in the third ventricle. For the occipital transtentorial in my cases, this is one of them. And the histology, looking into the grades of the meningioma, and myself and my colleague, Dr. Abu Farsakh, we published our last 250 consecutive meningiomas and looked into the results. And we found that grade 1 is very common in females, as usual, as expected, while grade 2 and 3 were more in males. And we found that the higher the Ki, the worse the prognosis, the higher P53, the worse the prognosis, the lower progesterone is the worse prognosis. This is the paper, which we published in the American Journal of Pathology. Radiosurgery, it was mentioned that we had the first gamma knife in the Middle East back in '96. We were country number 13 to acquire that, and this is me performing the very first gamma knife on vestibular schwannoma. And this is the gamma knife being used on residual tumor meningioma of the Farcotorial area. I will just take you through illustrative cases of mine. 45-year-old female patient, 32-year-old male patient with this meningioma that was operated upon outside Jordan in the Gulf area. They managed to take part of it, but most of it remained. So he was operated at St. Elsewhere outside Jordan. Following that, he came to Jordan. And this is what they have achieved. It's nothing much, with much damage to the temporal and occipital horn, occipital lobe. And you can see that the tumor is really going through the hiatus. And you can see the involvement of the straight sinus in this case. Surgery, I hope it will work. And again, we have to go back. This is in 3D, so we're trying to make it in 2D. All my cases are recorded in 3D, but because this is a webinar, so we cannot really. This is a case, and just go back. You can see here the embolization material. In this case, it was a giant meningioma. It was operated upon before, so I had to resort to embolization, and you can see the embolization material. If somebody of you had the binocular vision glasses, put it on. Otherwise, bear with me. This is the 3D demonstration. Here we are on the tent. And the Tintorial hiatus is here. The embolic material, the tent, and the hiatus in here. Now we're going through the hiatus, following this tumor. We are now entering the quadrigeminal system, and in a while you'll see the vein of Galen and junction with the straight sinus. As we said, that the aim is a gross total resection, and we have achieved that by just working and being patient. Following the tumor into the hiatus, I'm going now infratentorially. opening the tent, the junction. Straight sinus was occluded. We are opening. In spite of this, there's some bleeding there. So taking that part of the tumor attached to the straight sinus and the tent. You can see the venous structures there. Vein of Galen. This is the post-op. Remember, he had this huge tumor here. I think we have done a very good job here, preserving the brainstem and the venous sinuses. And this is the patient who came to us with total hemiplegia. He could actually raise his arm within a month's time without involvement of his eye movements. Case number 2, 37-year-old male patient with this extensive tumor. Again, preoperative, very intimidating kind of a tumor. And this is the postoperative. We have to leave a residual here. And again, here the surgery. We'll try to fix it. Here again, we went supracerebellar infratentorial. Separating the tumor from the cerebellar surface. Now we're coming to the area of the hiatus. Tumor which is just sitting on the inferior surface of the tent. And so on. And this is the patient post-operative. Another case, 47-year-old male patient with this extensive tumor. Again, very intimidating. Post-operative, a case, 55-year-old male patient with this tumor. I will skip the videos because time is running out. This is the post-operative. And this is the total straight sinus tumor that we have removed in post-operative. And their post-operative views. With this, I finish, John, and I'm happy to take your comments and answers and questions.
Okay, you are. Hello, Juha, are you there?
Yeah.
Okay.
I have some difficulties in starting the video.
Okay.
Now coming. Okay, thank you very much, Professor Ibrahim Sbeih, for this wonderful, very profound lecture and for the difficult meningiomas, Farcotorial meningiomas. So the lecture is open for discussion. Please go ahead.
Hello, Dr. Ibrahim. Just to congratulate.
Hello, Victor.
Excellent, as always. Tentorial, Farcotorial meningios seems easy to treat, but you remark the microsurgical anatomy, especially the venous sinus, so the deep venous sinus, I think is the most risk doing the surgery. Have you ever had bleeding of the rectus sinus, and how to treat this?
Yes, Victor, I did.
The galeno vein also.
Yeah, I did not have bleeding from vein of Galen, but I had bleeding from the straight sinus. And I managed this by putting a suture in there. Although in that particular patient, it looked like the straight sinus was completely closed. But as we were removing the tumor, some of it was still patent. So we had to put a stitch in it. I just used 9-0, 10-0 sutures to close the venous. And if that does not was not enough, and then I'll put a muscle with the glue on it. So yes, I did have some cases.
Thank you, Dr. Sbeih.
Thank you.
Congratulations.
Thank you, sir.
Some other comments? May I ask you, why is the surgery so long lasting, up to 23 hours?
Not my cases. This what I said is what is written in literature.
I'm asking, what is the reason for such a long surgery?
This was mentioned in McDermott's book that this is lengthy surgery and sometimes it takes this long. The longest surgery it took in my hands was 12 hours, but others are reporting 15 and 18 hours. It is very risky, especially if you put the patient in the sitting position. That will take time by putting him in the sitting position and then finishing the surgery, putting him back. So this is also calculated.
Okay, some other comments? Questions?
Yes, Harshad. Harshad Parekh has a question. Go ahead, Harshad.
Hi. Hello, Professor Ibrahim. How are you?
Fine.
Excellent lecture. I'm the great fan of yours, and I attend your all Jordan neurosurgical rounds many times and wonderful job you are doing in Jordan. And this is one of the most difficult part is the Falcotorial meningioma. It's one of the rarest. I agree with you. And the biggest problem is the total excision to achieve Simpson grade 1 or 2, even if you can say. The problem is the recurrence. Sure. They recur very much because you cannot remove. As Victor says, the bleeding from the sinus is a big problem. Which, if it starts, you are lucky you didn't have a bleeding. In my experience, unfortunately, I'm not as lucky as you, but I got majority of them are recurrent meningiomas. And they bleed like a tap, from the sinuses. Sometimes you have to ligate the sinus and you end up with some this problem. How to handle is difficult. And I have seen the results from many, many surgeons, and the results are not as good as like any other meningiomas. So this is one of the most difficult part, and you have given very elaborate description of the full spectrum of the Falcotorial meningioma. I just had a small query. Suppose you see an incidental Falcotorial meningioma, which comes on an investigation of a headache. What do you do? What do you advise to the patient? How do you tackle this problem?
Right. This is the major broad topic of incidental meningiomas. I've never operated on incidental meningiomas. Yeah. And when we say incidental, we mean that there is no complaint or a minor complaint, like headache or very minor. So I've never ever operated on incidental meningiomas. They have to be symptomatic for me to go and carry the risk of doing the surgery for such a patient.
Yeah. And second is the meningiomas arising from velum interpositum. Although I don't know whether we should include them as a Falcotorial, although the location is there, they are all called pineal region tumors. And what are your problems you can face when you are removing that meningioma? because you are surrounded by internal cerebral vein, vein of Galen, vein of Bitentorial, and this meningiomas may be infiltrating of those veins.
Sure. As I said, we should not include the vellum interpositum meningiomas with the Farcotorial meningiomas.
Yes,
They are
yes,
different kettle of fish.
yes,
And
yes.
most of the time you discover this when you are operating. If you find a dural
Yes.
attachment, this is Farcotorial.
Mm.
If it is not, this is vellum interpositum. But it is the same surgery like for any pineal tumor. You are surrounded by dangers. You are surrounded by explosives. But this is the type of surgery you are doing. You have to accept that.
Absolutely. And I agree with you. And Victor always says the venous anatomy, you must learn. Meningioma is the surgery of veins.
Absolutely.
If you can preserve the veins, you can treat meningiomas anywhere and remove it. And if you can't, then you end up in. So wonderful. I appreciate your complete efforts to explain the various types of meningiomas, all the classifications you have covered. Super. We don't see very often Farcotorial meningiomas, as you have also encountered. In last many years, I hardly has done 5 or 6 cases, but unfortunately, my all cases were recurrent.
Thank you.
Okay. Right. Thanks. Congrats.
I see Professor Benedicto Colli is here also. Would you like to comment?
Yes, I'd like to congratulate Professor Ibrahim for this brilliant review of this difficult topic.
Thank you, Benedict. Thank you.
Regarding the stretch signs, we recently published a paper where we described a case that we could dissect the stretch sinus because the stretch sinus is a vein between 2 layers of dura mater. And sometimes you can dissect completely, remove completely the meningioma from the sinus without touch the real wall of the sinus. Yeah. Thank you very much.
Thank you, Benedict. Thank you very much.
Jabber Abawi has a question. Jabber, do you want to ask that question? You have your hand raised there. Perhaps not. Okay. Any more comments, questions from the panel? Quiet panel, Juha.
Okay, then we thank Professor Ibrahim Sbeih for excellent lecture. We thank Subin for Chinese translation and the Takeshi Kon for Japanese translation and all the participants. So we go forwards. Next Friday, Professor Peter Vygotsky from Berlin speaking. So until next Friday, have a good night in China and good day elsewhere.
Okay, we'll
Thank you,
see
sir.
you. We'll see you. Thank you, Dr. Sbeih. We'll see you next
Thank
week,
you. See
everybody.
you. Thank you very much.
Thank you, Dr. Sbeih.
Thank you.
Thank you,
Dr.
Dr.
Sbeih.
Yuka.
Thank you.
Thank you.
Thank you.
Thank you.
All of you. Thank you.